Rahim. Myself, Mohammad Wasim, and I'm working as a regional sales manager in Nabiqasim industries. So hopefully you and your families are doing great and safe during this pandemic. So first of all, welcome to all our respected healthcare partners to this very important scientific event on diabetes and depression. Nabiqasim has always been extremely proactive as far as disseminating therapeutic knowledge is concerned. So therefore, in continuation of this webinar on the role of EchoMelatin, Morton in treating co-morbid depression with diabetes has been arranged. So for this session, we have with us very renowned and leading consultant physicians and psychiatrists of the Pakistan. So thank you so much for joining in from your busy schedule. I would like to request Professor Aftab, sir, please take up the session.
Bismillah Rahman Rahim. I'm very grateful to you for your kind introduction, but I can tell there is a disclaimer that there are greater physicians amongst the panel here this afternoon, and I am very privileged to have Professor Javed Akram, Professor Azizur Rahman, and Professor Tariq Wasim sat in this same boardroom where I am. Professor Amir Shaukat, you are also listening to us. I am very grateful that you joined this afternoon. So the topic is depression and diabetes, and both are great menaces of these times. Diabetes and depression both are overwhelming, and the numbers are staggering. And I'll share with you, type 2 diabetes and depression both cause ill health. Pakistan is ranked 3rd in prevalence following China and India. So this is not a good thing. We are taking precedence over even US now, and 33 million people are living with diabetes in this country, and 7 million living with depression. Or jo depression wali life hoti, this is hardly a life. It is can't be called living. वो जैसे गालिब का एक शेर याद आ गया, कहूँ किससे मैं कि क्या है शबे गम बुरी बला है, मुझे क्या बुरा था मरना अगर एक बार होता. तो यहाँ डिप्रेशन वाले रोज मरते हैं. And there was a study conducted by Ahmed Farhan, which was also published in Journal of Ayub Medical College in 2017, and they studied that depression was found in up to 26% of type 2 diabetics. So very high prevalence amongst diabetes. This is another study which is by Abdul Rahman Arshad, and the data it says, I have summarized it on this slide, of all the patients which presented to that hospital, 38.35 were depressed. और जब मैं भी OPD में बैठा होता था in the teaching hospitals and now in one of the private hospitals, I see depression is rampant. Of all the patients of type 2 diabetes, 38.35% were depressed. So this is a graph which is showing that depression negatively affects the glycemic control. The glycemic control is being seen by looking at the number of HbA1c, and the golden line is of depressed people and the blue line is of non-depressed people. So just having depression makes your glucose control worse. There is a bidirectional association. If you have depression, you have a greater tendency to have diabetes. And if you have diabetes, you have greater tendency to have depression. One makes the other worse and one makes the other come. So not only they're associated with each other, they negatively affect the outcome in each other, and both are very common. So this is a busy slide, and it tells you that what is affecting us and why is depression so common. So first are the external environments. Some people, when they go out and they feel, if you're depressed, you really find everything bad. Einstein ne kaha tha, there are two ways to look at life. When you go out, you can see and feel that everything is a miracle, or you can see and feel that everything is not a miracle. So it's up to us to decide. So external environment does play a role, and neighborhood, poverty, childhood bad influences, childhood trauma, ये बड़ा ही आजकल common चीज है जिससे बहुत ज़्यादा काम हो रहा है. Then there is intrauterine environment. This is also very dear to our Honorable Vice Chancellor Professor Javed Akram, and he says, and everybody now believes, and there is sufficient evidence that if you have bad intrauterine environment, fetal nutrition is bad, maternal stress is there, fetal stress comes with it, and you are more likely to have diabetes in your later life. And poor health behaviors, obesity. When they combine with poor thinking, I mean, when you have a negative attitude, then these things, they blow up. And then what happens if you have obesity, if you have bad environment? Single thing that really makes the disease come or afflict the humankind is inflammation. और ये कैसे होती है inflammation? There are genetic expressions. It is called as epigenetics. Influence of the environment on the expression of the gene. Hypothalamic pituitary adrenal axis. ये brain के अंदर where the circadian rhythm is being controlled, that is in the hypothalamus. And if you have a disturbed sleep, everything leads to inflammation. This leads to depression and diabetes. It also leads to increased incidence of cardiovascular disease, hyperinsulinemia, insulin resistance, and hyperglycemia. And they also affect neuroplasticity, altered brain reactions. So inflammation is at the heart, और इसको कहते हैं holopathogenesis. One thing that causes non-communicable diseases like heart disease, like stroke, like hypertension, like diabetes, depression, even cancer is mediated by inflammation. So association between duration of diabetes and depression. First, we have established that there is a negative correlation or a bidirectional correlation between diabetes and depression. Now look at the evidence for duration. More the duration of diabetes, higher the risk of depression. So Fuller et al. In 2016 have seen that increasing duration means increasing risk of depression. And Guru Prasad also said the same thing, that after 1 year you have a great rise in the incidence of depression amongst patients with type 2 diabetes. So what is the link? As I already told you, the link is inflammation. How is it brought about? By hypothalamic pituitary adrenal axis. जो हमारी body की clocks हैं, they are there in the hypothalamus and they are regulating the body. If it is not regulated, depression comes, sleep disturbance comes, poor mood comes, and comes along the inflammation. And there is also autonomic nervous system dysfunction, release of pro-inflammatory cytokines, and insulin resistance. And even the metabolic programming at the genetic level affects the outcome. So in utero and in early childhood, bad influences can lead to diabetes and depression, both in the later life. This is a very important part, and this is the thing which distinguishes EchoMelatin from other normal routine antidepressant drugs. The circadian rhythm is clocked by the master clock of the body. The master clock is in the prefrontal cortex above the hypothalamus, and it manages the circadian rhythm. It also determines our sleep, it also determines our moods, and it also determines how the body functions. And if it is disturbed, it also affects the insulin resistance, risk of type 2 diabetes, and it also affects our body in bad ways. So just look at this. The bar on the right extreme shows a mortality which is increased in patients who have both diabetes and depression occurring together. So the first thing is no diabetes, no depression, very little mortality. This is all cause mortality. No diabetes but depression, there is a significant increase. Diabetes and no depression, obviously this is a worse disease to have, and then there is an increasing mortality. But if you have both, जैसे कहते हैं ना कि diabetes and hypertension are bad partners, they make the mortality worse. It is that diabetes and depression are terrible partners. Not only they take the pleasure of life away, they kill you also. So what does American Diabetes Association and International Diabetes Federation, what do they recommend? Recommend that if you have diabetes, you should screen people for depression. अब depression का तो ऐसा कोई टेस्ट है नहीं HbA1c टाइप या fasting glucose के ठक diagnosis हो जाए. Here तो you have to be considerate, you have to listen to the patient and give time to the patient, which unfortunately some of us do not have. But we have to make sure that that time is available to our patients, because we have to give good care to our patients. So what is the impact of depression and diabetes? Not only there is an impact on mortality, as I told you, there is an impact on the economy, on the medical cost. If a person with diabetes have depression, the cost of management is 50 to 86% higher, and 4.5 times higher medical expenditures than with patients of diabetes alone, up to that much. So this is too much. So how to go about it? We have, as a general physician, to understand that we must suspect depression. And then we screen them and then diagnose. And once we diagnose them, we should treat them with the drug that is different and offers more than just simple SSRIs offer. So this PHQ-9 is the patient health questionnaire, and there are 9 simple questions, and you usually ask them during history taking, and this has been termed as HbA1c for depression. But it is not done by the lab, it is done by the treating physician. So what are the 9 things? And then there is a score you give. Loss of pleasure. You no longer take interest in doing things you used to. Change in sleep patterns. Koi bhi change. Either you are sleeping more or you are sleeping less. Early to rise. If you wake up early and then cannot go back to sleep. Change in appetite. You can eat more. When I am depressed, I tend to eat twice. I already eat 1.5 times. And some people, when they are depressed, they eat less. They cannot hardly eat. And if they do eat, then they can actually feel sick or have vomiting. So 5th is trouble concentrating. You can't really like to watch a long TV program or a serial or a season, and you don't read. You cannot concentrate. Same about the work. You cannot concentrate on your professional work or assignment. Loss of energy. You will be tired all the time. Ye to bada common hai. Overworked, burnt out, loss of energy. Guilt. You feel that you are no good at anything and that nobody bothers about you and that you are a burden to others, and that you feel terrible all the time. Morning sadness and suicidal thoughts. वो हम एक दफा मेडिकल स्टूडेंट थे, तो टीचर ने कह दिया कि पूछो भाई मेरे साथ जो था कि आप इनसे सवाल पूछें सुसाइड का, तो उसने कहा जी आपका मरने का दिल करता है. It was such a simple question, but this is what it is. They have no sort of will to live, and if you have 2 or 3 or more symptoms for greater than 2 weeks, so I'll go run through them quickly. Loss of pleasure, change in sleep patterns, early to rise and then not going back to sleep, change in appetite, which can increase or decrease, trouble concentrating, loss of energy, guilt, morning sadness and suicidal thought. Morning में तो ये होना चाहिए ना कि आप उठे हैं, enthusiastically, and you are full of energy and you wish to go to your work or whatever you are doing. तो अगर ये चीजें नहीं हो रही तो और 3 इनमें से नहीं हो रही for greater than 2 weeks, it means that there is depression and you have to have help. So what are the treatment options? Cognitive behavior therapy. वो कहते हैं जी दवाई के बगैर भी ट्रीटमेंट हो जाता है. This CBT, cognitive behavioral therapy, is very difficult. You have to have regular sessions. It comes, you have to give time. Some people don't. I think this should be an adjunct to treatment with medication. Other types of psychotherapy and antidepressant medication. So this is the timeline which tells you that first antidepressant, 65 years ago, first antidepressant was found, imipremine, tricyclic antidepressant, and they have really stood the test of time. They are still being used, but they have some side effects, and they do cause sedation, and then they can also cause cardiac arrhythmias. Then came first SSRIs. 35 years ke baad after tricyclic antidepressant, and then came SNRI. So SNRI, the venlafaxine, as you know, is better for anxiety and depression. And then came 2009 EchoMelatin. EchoMelatin was licensed in Europe. It was produced by Surveyor, the Surveyor company, but then they sold it to Abbott. And EchoMelatin has been used since 2009 in entire Europe as well as in Australia. And it has been found to be very effective drug. It also underwent lot of trials for FDA approval, but in some time down the road, Abbott decided not to pursue FDA approval, so it is not used in USA. And then came Viazodone and vortioxetine. This is the new kid on the block. And I'm going to focus the rest of my talk on EchoMelatin. Mortality, 25 milligram tablet. What is the mode of action? It works on your master internal clock in the hypothalamus through melatonin 1 and melatonin 2 receptors. उनको ये stimulate करती है. It is agonistic for MT1 and MT2 receptors, which are melatonin receptors. It normalizes the circadian rhythm. Surprisingly, it does not have any effect on serotonin, and still it is very effective. It also blocks 5-HT2C receptors. उसका नतीजा क्या निकलता है? कि there is increased dopamine and norepinephrine. So that is also antidepressant. It has got an extraordinary safety profile. It is not associated with nausea, sexual dysfunction, weight gain. There is some sedation with it and that can be used as a plus thing to be used in the evening. The dose is between 25 to 50 milligram, and it is classified as an atypical antidepressant. It does not alter the serotonin level, and it has master effect on the master internal clock of the body through melatonin receptors. ये सिर्फ ये बताने की कोशिश की गई है कि if you look at 6 parameters which include sedation, postural hypotension, cardiac conduction disturbances, anticholinergic effects, nausea and vomiting, and sexual dysfunction, EchoMelatin, which is in the middle of the left-hand side, which is the larger part of the slide, has a negative, except for sedation. So this is very good drug. It has sedation, some of it, but no postural hypotension, no cardiac arrhythmias, no anticholinergic effect, no nausea, no vomiting, and it has no effect or harmful effect on sexual performance. Cardiac safety of EchoMelatin versus other antidepressants. The first one is EchoMelatin, and I will read out the others for you. Just concentrate. Heart rate, no change. Blood pressure, no change. QTC, hardly any change. Single case of QTC prolongation. Arrhythmias, no arrhythmias reported. Conduction disturbances, unclear. And this is not contraindicated post-MI, and you can use it, but with caution, post-MI. This is effect of EchoMelatin on sexual parameters. EchoMelatin highlight karti hai, desire, arousal, and orgasm. It does not affect any of these negatively compared to other which some of them are really affecting them poorly. So desire, arousal, and orgasm are not negatively affected by EchoMelatin or Morton. EchoMelatin or Morton versus SSRI. It has better efficacy than Peroxidine, citrulline, and fluoxetine. It achieves lower HbA1c compared to Peroxidine, citrulline, and fluoxetine. It shows early improvement in depressive symptoms, approximately 2 weeks compared to other SSRIs, and it is probably because of resetting of the internal master clock of the body. And once this is discontinued, if discontinued, EchoMelatin does not lead to discontinuation symptoms. And it hardly leads to any side effects of sexual dysfunction. It has no effect on cardiac conduction, and it does not cause insomnia. It does not cause weight gain, and does not cause nausea and vomiting. हो भी सकता है, ये नहीं कि 100% नहीं होता, but compared to other, it is not associated with these common side effects. Comparison of Peroxidine and EchoMelatin in depressed type 2 mellitus patient, a double-blind randomized clinical trial. It may have some advantages, the conclusion says, against Peroxidine in the glycemic control of diabetes mellitus. So this has a promise which we can really materialize, and we can dwell on it and get the benefit. And there is this comparison with sertraline. Previously was with Peroxidine. This one is sertraline, and it also shows that fasting plasma glucose and HbA1c are better controlled with EchoMelatin. This was a pilot study, small study, but gives you some food for thought. Now look at fluoxetine with EchoMelatin. So this has a better, look at the average HbA1c level, p-value is less than 0.00001, 4 zeros and then 1. Point के बाद zero की वैसे value नहीं होती generally, when especially when it comes to your bank accounts or your fee, लेकिन इसमें ये बहुत valuable है because it is improving both the depression Thank you. So in summary, I'll conclude that EchoMelatin is a melatonin receptor agonist and 5-HT2C blocker. It improves the circadian rhythm. It improves depression. It has hardly any side effects compared to other antidepressants. It is more effective when it comes to the timing. It affects the symptoms earlier and relieves it earlier, and it also enhances norepinephrine and dopamine, and it has a positive effect on the mood. Thank you so much.
Thank you so much, sir, for your very comprehensive and very informative content which you have shared. So now I would like to take comment from Professor Ahmad Shaukat from Faisalabad. Sir, would you like to share your own experience? How do you managing your depressed patient with comorbid conditions of diabetes?
Thank you very much. First of all, I think like to compliment my friend Professor Aftab Mohsen for making a brilliant presentation and also feel more educated on this topic. Depression is very, very common in all types of patients, particularly in diabetics. And I think it is very, very heartening to know that we now have a product which can offer many benefits with minimum side effects. Many patients with diabetes, they have sleeping issues. So this one, once given at night, can resolve their this sleep problem. And over and above that, very, very heartening to know that this actually improves their glycemic control also. So my personal experience of using this drug is relatively limited because it is a new salt as compared to SSRIs, SNRIs, but wherever I've used, I've found it very, very effective and very, very safe. So it provides one of an additional option to handle these patients. They are already suffering from many, many conditions, many things, and depression is one of them. But I'm not sure. In fact, I would like to ask the worthy speaker if it has got any effect on neuropathic pains, because many times we have to give duloxetine to relieve neuropathic pain, which is common in diabetic patient. Does this EchoMelatin has any beneficial effect on neuropathic pain along with the treatment of depression?
Sir, I am not aware of any direct study mentioning it. Maybe there is an indirect effect because of the mood elevation, but I am not aware of any study this being used as controlling of neuropathic symptoms. But obviously, as you said, duloxetine and gabapentin, pregabalin, and lacosamide, they are all used, and they also serve as atypical antidepressants. So maybe we can combine those. But Professor Javed Akram is here, and I would request him, because he has a vast experience of using Mortality in his patients for a very long time.
Thank you so much. So I don't think EchoMelatin has that effect that will affect positively. I think for that, even the NSRIs, SSRIs, they all do not have a very good impact, and we rely mainly on tricyclics. Tricyclics are still the gold standard for painful peripheral neuropathies, along with obviously the basic metabolic control and so on. In majority of the patients, very soon the painful peripheral neuropathy and diabetes leads to a painless condition with the increased nerve damage. So that's the problem in the beginning, but not later on. Nonetheless, I think still, if we are looking to alleviate the pain of peripheral neuropathy, probably this is not a very good agent from that point.
Thank you so much, sir, for your valuable comments. So I'd like to take comment from Professor Tariq Wasim, sir. Would you like to share your own experience regarding EchoMelatin?
Thank you. The subscribers was wonderful to hear from our colleague, Professor Aftab Mohsen, and the only thing missing was that Sultan Bahu. Right. I think there are two phases of this depression in diabetic patients. The first phase is when they are misdiagnosed. The first discovery or revelation that they are diabetic, they make them depressed. And probably, I mean, I would like to have experience shared by us that what is the right time to start these antidepressants in the patient. And the second phase is when they have chronic illness and they are fed up with the medication and insulin and neuropathies and all that. And that is when they are really at that is possibly both their quality of life as well as the glycemic control, they get affected. So I feel that majority of our patients maybe sometime require addition or earlier institution of this medication, while right at the diagnosis you screen them for being depressed. That would be probably the best time, and that may have a positive impact, as you said. They would have a earlier or a better glycemic control that probably would take away some of the depression on that. The second thing which I would be, and that the good thing about this medication is just cardiac safety. Right? So Professor Aftab Mohsen very rightly showed that out of the previous class of drugs, particularly the initial imeprine group and which are using, they had quite a bit of problem with this, and then there are anticholinergic effects. So this is, and again, our diabetic patients are they are not having diabetes alone, majority of them. They would be on other antihypertensive, they would be on other. So drug interactions from that point of view and cardiac safety, that is probably it's a good point. As already Zisab said that since this is new to our market, we initially it was available. I remember it was available from October or something. But then we never saw it, and it is re-emerged in the Pakistani market, and we hope that we will have more and more experience with this coming years. And then third is very rightly said that we hardly suspect depression as a comorbid condition in our patients. So the simple questionnaire Aftab has shared, if we apply it to it, it hardly would take maybe not more than 1 or 2 minutes to ask these questions, or we may give it a sort of a pamphlet to the patient to check it out, and we can have that what is the degree or severity of this depression in these patients. And again, we can decide that whether we have to just counsel him and go for a psychotherapy, or as I said, marne ko dil karta to fir is the time probably starting earlier on rather than janaze ke baad kare. So that's I mean I feel that having its better say effect on glycemic control, good cardiac safety, and of course very little say interactions and no much adverse effect as was with the previous class of drugs, it definitely is going to be benefit our diabetic patients. Thank you.
So like Professor Tariq Wasim said that what is the best time to start it? I think the best time is when you find the patient depressed, and he also gave the answer that the best way is to look at the PHQ-9, the questionnaire, patient health questionnaire with 9 symptoms, and most of these are revealed by the patient anyways. If you're taking history, you spend 3 or 4 minutes with the patient, you know the answer that the patient is depressed. So the best time is to be aware of it, suspect it, and as soon as you discover, just treat it. And what is better than this, that you are treating depression with the medicine that also is favorably influencing the control of diabetes. And diabetes is rampant and depression is also very common. So it's a very good medicine for the use in patients with diabetes and otherwise also, because it's very safe and effective, and it acts more closely to the pathogenesis of depression, and just not only working through serotonin but working at the clock which goes haywire, and that causes depression. So these antidepressant drugs also help to fight inflammation, because once you are not depressed, then those inflammatory cytokines which the depression and stress is producing are not produced, and the outcome of both depression and diabetes are improved. Thank you. And
sir, thank you so much for your valuable comment. Now I would like to take comment from Professor Ahmad Shaukat. Sir,
I'm extremely thankful for all of you for inviting me to this wonderful webinar. Professor Aftab Mohsen is my favorite speaker, and he's very nicely elaborated on the correlation of treating depression in diabetes mellitus. I've always been an advocate of adding any drug that improves the quality of life in a disease which has got a chronic aspect to it, such as hepatitis C, diabetes mellitus, congestive cardiac failure. So over the years, we've learned that any drug that improves the quality of life, makes or brings you a feeling of well-being, is obviously a very, very good agent in managing these chronic disorders. The correlation of diabetes and depression and hepatitis C is now a well-recognized fact. And I think this drug should be a wonderful tool if its safety profile is as good as what has been said about it. And number two, because we finally have come across one agent in which we are sparing out the serotonin effect. So I still would think that probably since we are so much overwhelmed in the market with these selective serotonin reuptake inhibitors, my question to the audience and the speaker here is that would you be able to combine this drug with a selective serotonin reuptake inhibitor if for that matter the depression is not getting any better? Because this mode of action is pretty unique to us and is difficult and is different from the other agents that we know that work in depression, number one. And number two, the problematic thing that you see in depression is diabetic peripheral neuropathy. And the diabetic peripheral neuropathy always hampers your quality of life. And to me, I think that this drug probably won't have any effect on the peripheral neuropathic pain. And then again, you would probably be adding a pregabalin salt or a duloxetine salt in addition to this agent. So I would sort of recommend, and I would suggest that if you could come up with a comprehensive sort of a formulation in which you could combat depression, do something about the diabetic peripheral neuropathy, then also not forget at the same time the serotonin axis. These all things need to be taken into consideration. Thank you.
Sir, thank you so much for your valuable comment. So would you like to add your own comment, Professor Aziz? Okay.
Right. Sir, after Mohsin sahab aap comment kijiye na is pe. What do you think?
Okay. So thank you so much, sir, for your valuable comments. So at the end, here I would like to add one very important point, that Nabiqasim patient safety is our first priority. And we never compromise on quality efficacy of our drugs. So if you come across a patient with depression along with diabetes, you can surely extend the benefits of our quality brands like Morton, as prescribed and discussed by Professor Aziz, Professor Mohsin, Professor Tarak, and Professor Amos Shaukat, and Professor Javed Akram as well. Our product manager from Karachi, Dr. Anika, for closing remarks. Sorry.
Assalamu alaikum. Thank you so much, Wasim, for inviting me.
Javed Akram sir, please conclude the section. Then I would like to invite Dr. Anika from our head office.
Okay, sure.
Thank you so much to Nabiqasim
and the entire team. I hope everybody can hear me now. I was just thanking Nabiqasim and their entire team for this effort. I think a very important topic, diabetes, especially in a country like Pakistan, where we are one of those 3 countries where most of the diabetics are living. And also, we unfortunately remain a very depressed nation because of the environment that we live in, the uncertainties looming, and also the ongoing conflicts, whether inside or outside the office or the home. So endogenous and reactive. Both depressions are very, very common, and much more common, as very elegantly showed by my dear colleague, brother, Professor Aftab Mohsen. Obviously, we all know melatonin is a naturally occurring product in our body, which helps us to sleep. And obviously, it is something which already is present in the body, and the boosting of that and exogenously or endogenously improves the sleep patterns. Much data is available, and also address the depression to a much extent. As by Aftab very elegantly highlighted the EchoMelatin, and especially helping the diabetes control, which is as important as also not at a lot of cost as far as the side effects of the drugs. Very well tolerated, hardly have any side effects, no addiction potential, which is very important from my point of view when we are looking at the drugs that we use in these sort of disorders, whether it and also very safely combined with other antidepressants, because if there is a severe depression, obviously we these days resort very early on to combination of drugs rather than pursuing the monotherapy. Very grateful to my co-chairs here, and Professor Azizur Rahman, Professor Nabiqasim, and of course joining us from Faistabad, Shaukat. I think it has been a very educative session for me, and I'm sure for my colleagues who are joining us online. And once again, very grateful to Professor Aftab Mohsen and the entire team of Nabiqasim. Thank you so much.
So thank you so much for your valuable comment. So before wrapping up our today's sessions, Professor Amar Shaukat wants to add another point. Sir, over to you, please. Professor Amar, can you hear me?
There's a technical issue with Professor Amar Saab's laptop, I guess. So maybe we can proceed to the next remark point.
Okay. No, I would like to request Dr. Anika, please pay a vote of thanks to all the worthy speakers, panelists, and moderators, and as well our participants. Over to Dr. Anika, please continue.
Okay, thank you, Wasim. I hope you guys can hear me. First of all, I would like to pay thanks to Dr. Amar Shaukat Saab for being with us and sharing his valuable opinion over the issue about diabetes and depression, and for the management and the treatment options available. Unfortunately, due to some technical issues, we cannot get him right here. Of course, I would like to pay thanks to our distinguished speaker, Dr. Aftab Mohsen Saab, for organizing this amazing presentation and talking on detail about this very important issue that is usually get ignored in the regular practices. And I would also like to pay thanks to all the expert panelists, Professor Dr. Azizur Rahman Saab, Professor Dr. Nabiqasim Saab, and of course Chairperson our Professor Dr. Javed Akram Saab for sharing his opinion over this. And I would like to pay thanks to all the participants for bearing with us. We just got some delayed because of some technical issues there, and of course because of PSL, but thank you all very much for being with us on today's session, and it had been a very great experience listening to all these experts and of course our speaker. I would like to also pay thanks to all the participants who joined with us and stayed with us in this. And you guys can ask questions if you have any on our Facebook official page about the queries, and we will try to get back to you as soon as possible with your queries solved. Thank you so much.
Thank you, Dr. Anika. So once again, thanks to everyone for your valuable time. So thank you so much. Thank you.
Thank you all.